Hello friends, our video blog from Harvard School of Public Health. Today we are hosting Jennifer Brockman from St. Louis, Missouri. Jennifer, would you like to introduce yourself?
Sure. My name is Jennifer Brockman. I'm a physician, by specialty a psychiatrist, and by subspecialty a forensic psychiatrist, and I'm owner and operator of the Center for Health and Wellness.
Great. Jennifer, opioid use is a public health crisis. What are the causes? Is there any association between opioid use and mental illnesses?
So some people have mental illnesses which they try to self-medicate or treat, and they take substances such as opioids. For other people, they have chemical dependency problems as their primary issue, and then they use, and that causes then mental health. So it's a bit like a chicken and the egg. But what we do know is that about 20% of the US population suffers from some sort of psychiatric condition, be it depression, anxiety, and those people account for 50% of the opioids that are being used. They have a higher risk not only of using opioids and for a longer length of time, but also suffer complications related to it more frequently, such as dependency and overdose, which kills about 100,000 people a year. Yes, there is an association both between chemical dependency and mental illness, and opioids are just one of that.
So what can we do as physicians and physician leaders to address that problem?
I think first of all, we have to remember that addiction knows no boundaries. So it could be our colleague, it could be an elderly patient. And I think that we just have to be aware and have those conversations with people, and sometimes, make the difficult choice either not to refill a prescription or to check the pharmacy records or to talk to other providers that they might be seeing in terms of what drugs they're taking and how it might be impacting them. I think also we need to think about knowing about resources for sending people for treatment, being aware that maybe there is a comorbidity in terms of mental illness, say depression or anxiety, that might be interwoven into the clinical situation we're seeing, even if we're in orthopedics. And then lastly, consideration of giving family members and patients remedies and solutions of what to do in crisis situations, like naloxone, so that if they do have an overdose, that the outcome isn't tragic.
Right. And there's one thing that I do, or I would advise every physician to do: not every pain should be treated with low tabs, and only pain specialists should deal with those type of medication, because meds like low tab or Percocet is kind of gateway to opioid crisis as well. There are 1 to 2 physicians in this country committing suicide every day. What are the causes and how we can address? Is it anything related to mental illness or like stresses of the job? Do you want to talk about that?
Clearly it's a major problem, and I'm glad that we're having conversations about it, and that physicians are hopefully becoming a little bit more willing to engage in dialogue with one another and with the systems that they work for, that it's a problem. Because for a long time there was stigma and there's denial. Clearly people don't kill themselves if they are happy and doing well. I think that the sources for that are multifactorial. Part of it is our depression rates are about the same as they are with the general public.
Right.
But given our knowledge and our access to lethal means, and then also personality type, when we attempt suicide, we more likely to complete it. And so we do have higher completion rates than other professions, which isn't surprising. And males and females actually have similar completion rates as far as physicians, and that's different than the general population. So I think over time, reducing stigma from mental illness, encouraging providers to engage in self-care, and just taking time out of our schedules to reflect on, how am I doing? We give. I think that part of it has to do with the same factors that contribute to so-called physician burnout. I think we work a lot of hours. We are placed in a lot of high-stress situations, whether it's saving a patient's life or whether it's facing litigation on an
Yeah.
ongoing basis. And so just knowing that there's a lot of demands, and self-care is okay, and seeking treatment when we need to. And I think reaching out to our colleagues when we see somebody might be struggling
Right.
with either a substance issue or with depression, and letting them know that's okay.
Sure, sure. So Jennifer, last question. You are a busy psychiatrist. What is your motivation to do this Master's in Healthcare Management program?
So, I think at this point in my career, I've had a lot of different opportunities to work with amazing people in different situations and in different settings. And there's common themes that I've seen in multiple different organizations. And I feel like a lot of the places that I have worked in or the projects I've been a part of could have done more. And if we knew how to organize better, address systems issues, have a better concept and ability to engage in conversations about business issues, that we could do more good.
Sure.
In a smarter and more efficient way. And so I was motivated to pursue this because I'm interested in looking at systems issues and being able to come to the table in multidisciplinary settings with people from the legal department and from the business department in order to have our voice known and heard.
And Jen, I think the big job of leadership is dealing with people. With your background of being a psychiatrist, and now with this financial and management knowledge, I think it will really help you in your future role as a leader. Thank you so much for your time.
Thank you. Thank you for having me.